Executive Director of Chag, my brother, Dr. Koforidua, and my name, Dr. Maxwell Anchi. Good morning to you, colleagues. Good morning to you, colleagues. Yeah. Dr. Dia, thank you very much. As it was described yesterday as the engine of Chag, we appreciate the work you are doing. And we appreciate the work of Chag, Directorate, Secretariat, the leadership of Dr. Pitaya. We are so grateful to you. The whole Chag community, we are grateful. We appreciate the good work you are doing. I think, okay, so they are trying to get the PowerPoint. So, the topic, when I saw the topic, I said this is a research topic. And those who crafted the topic are so intelligent that they have 3 dimensions in it. How do you build a resilient workforce? How can they contribute to quality healthcare delivery? So there's dimension there. And what are the financial mechanisms to ensure that they work? So 3. So I said this has 3 key variables in there. Those who are doing PhD or doing master's program, it's a very good research topic you can consider. So they have asked, I want to present data, and I think from yesterday's presentations, we got to know issues about health workforce, the challenges, and so this morning I said, can I add figures to some of the discussions yesterday? And so, from global dimension, I want to give a global picture of health workforce using the 2020 data that we had from WHO. And 2020 figures of health workforce globally. Globally, as of 2020, we had a whole total health workforce of 65.1 million health workers, made up of 12.7 million medical doctors, 29.1 million nurses, 3.7 million pharmacists, and 2.2 million midwives, 2.5 million dentists, and 14.9 million other occupations. That's the global nature of health workers. Now, in terms of Africa's share of global health workforce, right, as at 2020 had 2.8 million doctors, nurses, midwives, pharmacists, and dentists. So you look at the global picture, and then you look at even global number of 12.7 million doctors, and within Africa we had only 2.8 million doctors, nurses, pharmacists, dentists. Now, the Ghana situation. And this data is 2022 data published just in February, March by WHO. It's part of the work that we did. And we are grateful to some of the Chag members, the Chag HR team, and other specialists from Chag supported this. So, from training, you see that the whole country, health workers, we train annually, is estimated to be 55,548. And we have a total 2020, those qualified to work in healthcare was 208,382. Now, out of that, 39.7%, constituting 118,488, were unemployed, or I would say are unemployed. Now, when you look at the capacity of our training institutions, they can train up to 78,000. They can take up to 78,000 annually, of all, including universities, health training institutions, training health workers, and 71% yearly are utilized. So we utilize 71% of our capacity to train. So we still have some space to do more training within the current health training institution space. Now, if you want to work towards achieving the UHC targets as Director PPM presented yesterday, then we will need additional 498,758 health workers to meet at least 98% of the disease burden and aiming for a minimum of 80% UHC targets by 2030. And we look at attrition rates in the health workforce space is 3%. People will say 3% is something small. In terms of numbers, huge. Now, when you look at attrition itself, 63% of our health workers will want to migrate. And 38% of them have started working on their migration process. And 26% of them will want to migrate in the next year or two. So that's the data. Now, we want to see the progress made so far over the years from 2013 to 2022. We have seen increase in the annual density of health workforce by 31%. So that is massive progress there. However, the records show that on average, health workers are not yet earning the economic rent. So that is on record. Health workers are not yet getting what they need to get to live in the economy. Now, so the density, looking at it from the MDGs and the SDGs, when you look at the MDGs, you can see that there's challenge there. But you can say that at this time, if we were to go back to the 2000s MDGs per city, we have made progress and we have crossed the MDGs target. But for the UHC, we are yet to hit the UHC. So we have 82.75 doctors, nurses, and midwives per 10,000 population, which has been an increase of 11.6% since 2015. And so we have seen improvement in the densities. Now, next slide, please. Now, this is important to health workers, and this slide gives us the power to negotiate for increasing fiscal space for health workers. This is a research that was done by the McKinsey Global Institute in 2022. And this research is showing the economic power of health care. When you look at the picture there, you can see that we have the bottom black shows that for countries, the children that die too early, so infant childhood deaths. When you look at the United States and Canada, you see that the black is low. When you come to Sub-Saharan Africa, you have more childhood early deaths. And now when you go to the next level, we have disease conditions. And you see that in Sub-Saharan Africa, you have 41% of disease conditions. Now, the next level is expanded participation in the labor force. So when you look at Sub-Saharan Africa, it's just 4%, whilst America and Canada is 39%. And light green, which is the productivity level. So McKinsey did projection and said by 2040, this is how the picture will look like. Considering the dynamics of population growth, you see that in Africa countries we have more children and the more youth is high. When you look at the advanced industrial countries, they have aging population. So they don't have many children, and then the youth is so not huge as compared to most African countries. So what will make the economy to grow is our ability to expand, to increase participation in the labor front. So we have more people working, good jobs, and then once they are working, they can contribute to productivity and GDP will grow. So what it means is, because in Sub-Saharan Africa we have high disease, more disease conditions and early childhood deaths, we need to do so many things there so that we can keep the 36% of children in the labor force so that they can work and then contribute to productivity and high GDP growth. And who are the people to do that? It's only health that can do that. So it means that for the next 15 years, health must contribute to economic growth, to productivity, and to high GDP. For Africa, including Ghana, that is our tool to negotiate. Now, if Ghana is to grow, have a GDP growth of 0.5 by 2040, increase by 2040, then it means that need to implement interventions to prevent early childhood deaths, and also to help adolescent behaviors, improve behaviors, lifestyle, so that the youth can grow, and then the children will get there, and then we'll be more productive, and then we'll be able to have our GDP growth of 0.5. If you are not able to do that, then our GDP growth of 0.5 predicted will not be able to achieve that. So, ED, that is the tool for you to negotiate, to bargain for health workers. And WHO, yes, if health is the tool, health systems can only function with health workers. So, without health workers, nothing will work in health systems. So, that's the bargaining power for health to the negotiation tables with Ministry of Finance. If you want to improve economy, then health is the key. So, WHO in 2015, looking at the UHC and other things, said that let's have a global strategy for health workers. And the global strategy for health workers is how do we make available health workers equitably distributed? How can we access them with the required skill mix at all levels of care? And then how do we produce quality health workers with competencies, skills, knowledge, and attitude ready to deliver quality care? And how do we have the supporting system for health workers to work? And then with that, we'll have effective coverage and we'll be able to achieve the UAC. So I said, can we come back to the research table and have a research journey responding to the topic that was given, building resilient health workforce, the conceptual framework or conceptual model for Chag or for the country Ghana. Next slide. So this is our conceptual model, this is our conceptual framework, working towards building a robust and resilient health worker to withstand shocks and trusted by the people. That is why when health workers want to strike, we say, those in charge, by our moral principles, you cannot go on strike. We must withstand the shocks. That is why we are a resilient health workforce. So if you call yourself a resilient health workforce, others are going to strike, and then we have shocks and we are not able to withstand, then you don't fit to work in Chag. I'm sorry. So if that is what we want to build, then let's look at the independent variables that will give us that dependent variable. And the independent variables, per the theory, the theoretical framework developed by WHO, the strategy is making available health workers in the right numbers and the scores. Now, the caveat is, when we say health workers, it doesn't necessarily mean in numbers. Important is they are competent, they have the skills. They are distributed in the right mix and equitably distributed across geographical regions. Well motivated to perform and they're economically beneficial systems and right processes of care is for them, and then they can deliver competently and have positive user experience. So if all these variables will help us have a resilient health workforce at the macro level, then this resilient health workforce will provide quality healthcare delivery, which we are looking at. Then what are the moderating variables? And then we are saying that we want to look at finance as moderating these variables. How can the financial strategies moderate the variables? That's why I said this is a very good research topic. You can use this as your conceptual framework, go to the field, and see how they work. So, next slide. The key variables there, quality healthcare delivery. And whenever I hear of quality, my mind goes back to the early days of creation. I was not there. You were not there. But God created Adam and Eve, and God instructed them to do this and don't do that. And so God said, do this, I think this is the right thing. So when we look at the definition of quality from the gurus of Crosby, Juran, Deming, Donabedin, they all sum up to doing the right thing the first time and continuously right. It means that when God instructed Adam and Eve, if they had done the right thing the first time, we wouldn't be here struggling, crying. They refused to do the right thing first. So it has biblical connotation. So quality, biblical. And then we look at the story of David in the Bible. It has two dimensions. When in Psalm 51 verse 2, when David committed sin, and David was trying to hide sin, God exposed him. Now, when David, so that is the negative part of doing the wrong thing and hiding. So you do the wrong thing. Quality says do the right thing. You have done the wrong thing, and you pretend as if you have done the right thing. God will expose you. The fundamentals will expose you. Now, so the good side is when David sinned and confessed, God forgave him. So that is the good side of doing the wrong thing and admitting that I'm not perfect. I've done the wrong thing, but that is why Dr. Entry and his team, Bonnie, will always say that improvement, quality is improvement. We don't have perfection. So you keep improving on what you have. So how do you improve on what you have? Is when you admit that you are not perfect and there's room for improvement, then you continuously improve. So that is the good side of David. Sin, confession, forgiveness. Doing the wrong thing, admitting that it's a wrong thing, and then willingness to improve will give you quality. So God said in Luke and 6:46, why do you call me the Lord and do not do what I say? So this is also biblical. So if as Christians we want to do the right thing and continuously do that, then we are just following the basic principles of Christianity through creation. Now, let's go to individual resilience and the philosophical perspective. The anno fati, which is a Latin word, means love of faith. And that's the principle of all Christians, all of us here. And the philosophical point of Stoicism, which your actions, your reactions, your character, your attitude, and how you treat people. Professor Kosa yesterday said that. So we cultivate resilience through philosophy by practice of self-reflection at the individual level, mindfulness, and then well-being, showing gratitude to others and to ourselves, continuously examining our beliefs and attitudes. That enables us to grow as individuals, encourages us to seek out for our challenges, embraces our weaknesses or challenges as opportunities for growth, and in practice to do the right thing and continuously right. And that is quality care. So we need a resilient health workforce to provide quality care. That's the basic principle. That's why we are health workers. And so for our facilities, the core principle is how do we develop the health workers to be resilient and then to provide care, quality care. And one thing we always forget, and that is at the macro level policy, is that we always forget about the carer. So who cares for the caregiver? In most of our policies, we don't mention support for health workers themselves. And that is what we want you what we want our facilities to do. Because if you don't have strength, how can you provide care to others? So that should be the core principle, what we want Chag to champion, that our facilities must have assistance in the facilities to support health workers. Now, next slide, please. So this is what we want facilities to do. Provide supportive, supervision, information, communication, infrastructure, supplies, and then we foster trust in health workforce by addressing personal behaviors between providers and clients, employers and employees, and managers and institutions. And that requires training as well as effective leadership. So, with all the avoidable errors we commit, we cannot build a resilient health workforce with all the sophisticated equipment and infrastructure and continuously commit avoidable errors and pretend to be doing the right thing. For that, we cannot be trusted by the people. Our strategic options. Now, our recent study shows that for currently, the government is spending $750 million USD on health workers. And the private sector is spending $345 million on health workers. By 2030, government would need to spend $1 billion USD looking at the supply. And the private sector can contribute $476.7 million USD for health workers for us to attain the UHC. So overall, cumulatively, we will need 9.79 billion per year to support health workers. The question is, do we have the economy that can sustain this? Do we have the economy that can support this? Is which one first? Do we spend more on health workers to develop, to improve the economy, or we say we don't have it? We maintain the status quo. So that's the physical. The green shows that if you want to meet the need of health workers, the need of disease burden, that is where we must go. Currently, we are at the violet, where, please, next slide. Yes, next slide. Yeah. Go on. Yes, so for the need, that is, the violet is where we are now. And by 2030, if we want to achieve the USC, we need to increase the fiscal space of health workers. So financial financing, health financing as moderating variable. Next step, next slide. Yeah, we have two distinct aspects. We need to generate sufficient volumes of financial resources to cope realistically with HR need and sustain adequate levels of funding over time, improve government budgets and other financial mechanisms. We have ceilings on recruitment, the stagnant salaries of health workers in public employment, and hiring moratoriums limiting the expansion of health service and creating unemployment of health workers. That is what we currently see. So the financing options. The status quo, yes, we maintain the status quo, but we need to negotiate for increased government HR fiscal space, or we go back to our HSS instead of the single spine. I feel that that was the biggest mistake we have made. If we had maintained our HSS, then we can easily negotiate for salary increases. And we need to decentralize HR financing to agencies and regions. Private-public partnership in HR financing. And we need to strengthen the NHI. If we strengthen the NHI for people to pay right premiums, the NHI can take care of health workforce and ensure accountability. HR costs, we don't know. We don't know even healthcare costs at the moment. Can we look at examples from Robert Kaplan and Michael Porter in coming out with the right HR cost and right cost of care for NHS. Internally generated funds, we have about 15% of our workers paying them ourselves. But we can do it better if we are allowed to do co-payment, get top-ups, and then we can recruit some kinds of health workers and then manage migration. The Philippines way, they are doing that. You train more, prepare them well, you export, you get returns, you improve your HR or your training schools. Then we can also have health workforce credit policies, where if health is the key to economic growth, then health can go to discuss with government and engage even banks or these industries to help them set up a health workforce fund to support the health workers in training and other areas. Yes, we have donor-funded positions. It's an option I don't want us to go. We cannot continuously depend on external donors. The South African countries that have depended on donors now is being scratched and they don't have a substitute. So it's my suggestion, we shouldn't depend on donors for HR funding. Then we must have community health financing mechanisms where we will have community supporting some HR interventions, providing accommodation, providing some kind of support to health workers. And this is practiced in Nigeria and Kenya and even in Uganda. Then we have decent jobs in other health-related areas. The ecosystem of care must work, where we outsource some kinds of work to agencies so that they can employ health workers to do certain jobs instead of government taking everything upon their shoulders. There are certain key jobs, domestic care and others. Government must recognize agencies so that agencies can go into that area and then they can employ health workers who are home unemployed to do those things, and that will cater for the disease burden that we have. Then we must rethink the schemes, a paradigm shift. Dr. Dia presented yesterday that it's all about clinical nurses, doctors, not doctors. Now look, when we look at the disease burden, emerging disease conditions, you see that we have more of the chronic diseases and all these things. And these, we require people like the nutritionists, the physio, and the clinical psychologists and all these things. But we neglect, we don't recruit them. So that should be the schemas, that should be the focus going on. And the question is, do we need to recruit more specialists at a higher cost to do primary care, or recruit practitioners at a lower cost to do primary care services? Thank you. And for Chag continuously be helpful, please, let's take this quote from Albert Einstein, the great theoretical physicist, says that if A equals success, then the formula is A equals X plus Y plus Z, where X is work, which we are doing. Why? We shouldn't forget about having leisure and playing. And then the most important thing, Z, is keeping our mouths shut. Thank you very much, and God bless us all.
Thank you very much, Dr. Entry. I think he deserves another round of applause. Very grateful, Dr. Entry. Dr. Entry is known to have had a quote that says that healthcare without quality is like giving a patient poison to go and drink and die. Dr. Entry, thank you. Ladies and gentlemen, in the next session, we are going to talk about security measures for health institutions, the area that we have largely ignored. But we want to tackle it now. So to do that, I want to call COP Prosper Ablo, Esquire. He is a member of the Chag Board of Trustees, well nuanced in issues of legal and security. A round of applause for COP. I've been alerted to let you know, it's Commissioner of Police. If you didn't know COP. All right, COP, the stage is yours now. So just to give you a little context, he was Deputy IGP. Deputy IGP. We told you yesterday, we are bringing you nothing but the best for this conference. And that is why we are giving you high-profile people.
Dr. Chair, permit me to rely on the existing protocol. My topic is security measures for institutions. Next slide, please. Yeah, you can see the scope of my presentation. By way of introduction, we are aware that health institutions are more than just buildings. They are complex environments where numerous interactions take place between different stakeholders, such as patients, care providers, students in case of health training institutions, staff, and visitors. A safe and secure environment is fundamental to these interactions, and security measures play a vital role in establishing it. Now, one may ask, what is the importance of security in health institutions? Every healthcare facility aims to be welcoming, which necessitates an open door policy. However, this openness exposes facilities to numerous security threats, making them soft targets. The high degree of public accessibility amplifies their vulnerability. It is therefore important for health institutions to protect themselves, their property, assets, occupants, as well as visitors from malicious security threats. A securely established environment allows healthcare facilities
to concentrate on their primary mission, which is delivering quality health care services. Now we'll proceed to look at how ways to enhance security in health. Then we have 3 steps. The first step is security needs assessment, or evaluating security needs. Now the second is planning a security plan. This is based on the evaluation which you have done in step 1. This plan should outline the specific security measures to be implemented, including the deployment of security personnel. Now, one major component in the security plan is perimeter security. By perimeter security, we mean the measures and systems implemented to protect the boundary or perimeter of a property, facility, or site. It is designed to prevent unauthorized access and deter intruders while detecting security threats to alert personnel before a breach occurs. Perimeter security typically involves a combination of physical barriers, technological solutions, and operational procedures to create layers of defense around the perimeter. In the solid plan, security is thought of in layers. Protecting your premises from the outside in. So you start from the outside. The protection starts from the outside, and we work towards the inner layer. Working from the outside into the center. A security plan should have many layers or barriers which the potential criminal has to overcome, each one getting stronger the closer you get to the center to provide greater protection to your interior assets. This layered approach increases the level of physical defense as you enter deeper into the heart of the site and closer to the most critical assets to deliver what we term as the golden Ds of effective perimeter security. That is, to deter, to detect, deny, delay, and defend. Now I shall proceed to look at them one by one. The 5 Ds of perimeter security, namely deter, detect, deny, delay, and defend, work on the onion scheme principle. We all know onion. We use it in cooking. So if you cut the onion, it is in layers. So the security, perimeter security works along that line. So it is also called the onion scheme principle, whereby multiple layers of security work together to prevent access to your premises assets, giving you the time and intelligence you need to respond effectively. Now the first D is deter. That is on the outermost perimeter. And it is key to have in place some forms of visual deterrence, such as fencing, lighting, and signs. This can be an effective way of dissuading potential intruders before they even attempt to breach your premises. Now we look at detect. Being able to detect trespassers is vital. This can take the form of motion detectors, CCTV cameras, and other electronic surveillance methods, which can sense and record any intrusion on your site. Now the fourth is deny. This is all about denying entry to your site, or even its most sensitive areas, with access control solutions, from manned security gates to customs. You can manage who goes where on your premises. Now the next is delay. So when all what we talked about have failed, the next step is to delay the intruder. And a range of security solutions can be utilized around your perimeter to delay an attack, such as parking controls, road blockers, and interior barriers, all of which can slow down an intruder and offer valuable time to deal with the security breach. Now the final D has to do with defend. This is the final and innermost ring of security, which usually involves your security team. That is when the intruder has breached all the earlier Ds and entered the last phase. Now your security team or the police will have to come in to apprehend the intruder. So this is how the 5D perimeter solution looks like. You see, it's an onion cut, and then we have the layers. The outermost is to deter, followed by detect, delay, deny, and defend is in the innermost or the innermost ring. Now the third step, we have looked at 2 steps. First, analyzing your needs. Second, drawing a plan. And the third step is implementation of the security plan. Now, I'll have some key takeaways in developing and implementing a security plan. The first is you have to increase surveillance, all waiting rooms, the emergency room, hallways, entrances and exits, parking lots, and other public areas should be monitored at all times. Posting a notice that the area is being monitored helps to detect many threats. For instance, those who have dogs in their premises, you see they always post a notice, beware of dogs. That alone serves as a deterrent to a would-be criminal. For optimal security, use cameras that can be remotely repositioned as needed to see different angles. Now the modern cameras, you can even manipulate them on your phone. They link them with your phone. Even if you are outside the country, you can always see what is happening in the premises. You can manipulate the camera in such a way that you see all the corners. Now you secure your parking areas. Sometimes we are very oblivious of this. The fact that parking areas can also pose as security threats. Parking lots should be well lit. Lighting is very, very key in perimeter security. Monitored Sorry, there's a spelling mistake there. With cameras and even patrolled by on-site security staff. If possible, having the lot blocked off with gates helps. You don't just leave the parking lot open. If you put in gates, it also helps to deter or to prevent breaches. Now we limit available entrances and exits our facilities, especially the hospitals and schools even. You don't have to have several entry points and exit points. You limit the access. And the more entrances and exits a facility has, the harder it is to declare, to secure them all. For staff-only entrances, create electronic entryways that can only open with the correct key card, passcode, or even biometric login. I saw this at Ridge Hospital, the new Ridge Hospital. Their security apparatus is very well, or top class. For non-essential entrances and exits, turn those into emergency-only exits that sound an alarm when opened, so that if you have an intruder, as soon as the person attempts opening it will trigger an alarm. Then monitor IDs at entrances. Outside of the emergency room, ensure someone is checking IDs at the entrances. This prevents criminals posing as doctors. Yesterday we had Lawyer Jay taking us through, and he talked of a criminal who posed as a doctor and went and sat in a consulting room. It also prevents families sneaking into areas they shouldn't be in. This is difficult to implement in hospitals, but it can work in some areas of the hospital. For example, the emergency room, the pharmacy. There are certain key areas that this can work. Increase on-site security staff. Sometimes we don't want, security is very expensive. So you have to employ a lot of security staff on your premises. Doctors, nurses, and patients are not exactly focused on the environment around them. They are not watching for suspicious activity. They are all too busy with their daily tasks and dealing with illnesses. This is where increase in on-site security staff helps. Have security guards available on each floor, around the perimeter, and around parking areas. Access control. Restricting who comes into the emergency department, wards, and parking lots will help to keep the healthcare facility secure. Access to these areas can be controlled by using manned security services, automated barriers, or CCTV systems. Staff can also be issued with electronic key cards to allow them to access all areas of the facility safely and securely. I visited a patient at Ridge Hospital. He was in the emergency ward. That was where he was admitted to. And I couldn't enter without being given access. Somebody had to come and use the card to swipe to open the door for me to enable me enter. So that is how secure the place is. Drones. Now we are now in a technological era. Drones may not be the first thought when it comes to increasing security in healthcare facilities. However, they are ideal for keeping an eye on rooftops and outdoor areas where patients, staff, and visitors congregate. They are also ideal in emergency situations to help guards keep track of security threats so they can get everyone to safety more easily. Now, electronic entrances, I've already talked about that. That is, the door will open when you are approved to go in. This allows health facilities to monitor who comes and goes, and it also makes it easier for security staff. Now you should use remote guarding 27/4. Having security cameras is not helpful if they are not being monitored. Using remote guarding services ensures your cameras are monitored 24/7. Not only does it keep staff, patients, and visitors safe, but it also helps to discover if any staff are stealing or treating patients badly. Now, wearable panic buttons. There are buttons that you can wear. Then a quick press of the button alerts either management or the security personnel of any security threat. Now, something that we have always not considered is cyber considerations. Security concerns in digital healthcare encompass the protection of patients and in case of training schools, students' data from unauthorized access, breaches, and cyber threats. Medical information must be kept secure if patient safety is to be fully protected. Implementing cyber hardening technologies such as network monitoring software and end-to-end encryption and the elimination of backdoors are a few best practices. A few years back, we handled some cases at CID headquarters. 2 tertiary institutions, their systems were hacked into with a view to what? Changing the grades of the students. We arrested them though, but we couldn't make it public for the sake of the institutions involved. They are investors. And one of the perpetrators, one of them, he offered to assist the university to make their system more secure. And we also arrested a 19-year-old boy who hacked into the system of a bank, a renowned bank, and was able to move funds out. 19 years. And he called himself the Hitler of the net. But in US, they use such people, FBI uses such people to hack into the people they are monitoring systems. Now, emergency preparedness, establish thorough emergency response protocol in collaboration with local law enforcement agencies and emergency services. So you should make sure that you are always in touch with the local law enforcement, so that in case of emergency, then they can always come in to assist you. Then collaborative partnerships. Collaborate with local authorities, maybe local assemblies, neighboring institutions, and community organizations to foster a safe environment and on and around your premises. These partnerships will enable you to stay informed about local safety concerns and implement appropriate preventive measures. Now, something that a lot of employers don't do is either there's identification or background checks before staff are employed. I don't think you do that in your hospitals. It is very important. It is done for a fee, but it's very minimal. It used to be 20 cedis those days when I was at CID. I don't know how much they charge now. We have a database, the police have a database of criminals. And now it has even been automated. So when the fingerprints of the would-be employees are taken, they are fed into the database. And if the person has once committed a crime and a record is kept of him, it will show. We arrested somebody who had 10 previous convictions with 10 different names. You can change your name, but you can't change your fingerprints. Even identical twins don't have the same fingerprints. Their fingerprints are not identical. So he changed his name 10 times, but we were able to arrest him by use of the fingerprint. Somebody applied to join one of the security services, and the fingerprints were brought to the CID headquarters for verification. And it was found out that he was a jailbird. He had a previous conviction. He was even already in training, so they had to withdraw him. Yeah. Okay. I'm about wrapping up. The mental health and support services. Yesterday, Dr. Adua talked about, or made us aware of the fact that some of our facilities have started providing mental health care services, which is a feather in our cap. But what about our own workers? A secure environment extends beyond physical safety. Put measures in place to support the mental well-being of healthcare workers and students of health training institutions, in case of training institutions, including counseling services, peer support groups, and access to mental health professionals. So we shouldn't forget our own when we are treating others. Then reporting mechanisms. Establish clear and accessible reporting mechanism for any safety concerns or incidents. Additionally, engaging with healthcare workers or students to educate them about safety protocols and encouraging them to report suspicious behavior can help create a safe environment. You are all aware of this popular term, which was circulated by National Security, but they also took it from somewhere. It's a global term which is being used. If you see something, say something. Yes, so we must inculcate this in our workers as well as students. Now let me conclude. In conclusion, permit me to emphasize that providing a safe and secure environment should be a top priority for management of health institutions. Thank you for your kind attention.
Thank you very much, COP. Another round of applause for him. Deputy IGP has given us a lot of tips. I like the wearable, is it detectors? Panic detectors. At this point, I want to hand over to the chairman.
Good morning, colleagues. We will first invite questions and comments to the two presentations that we've had. So the floor is open for questions and comments. I have a few, but I want to hear from you first. Yes. You have microphones.
Good morning. My name is from Farm Access. And the question goes to the Dr. James Antwi. Very nice presentation about the shortages of healthcare personnel. What amazes about 39.3% of them is unemployed. Same time, you're asking Chag to advocate for health personnel. So I find it to be a bit inconsistent that there's unemployment and at the same time shortage. So could you explain that a bit?
Welcome to Ghana. Any more? So the question is, how come that we need more health workers and yet those who are trained are unemployed?
I'm Simon Bekon from Jamasi, Pope John Paul. My question is for COPD. COP. Sometimes we employ some security personnel in our facility. Then they ask us what can be provided to them. Because more or less, they are handicapped when intruders come in. What can we give to them? What can be provided for them? And what is the limit? Because we don't know what to be given to them. So we want an explanation from that. Thank you so much.
Can we give the security people who employ batons, raffles? That's the question he's asking.
I am Riafe Echampon Kofi. I want to ask a question with regards to the security issues. I am currently working in a clinic, but previously I was at a hospital. The HR requirement for staffing in the clinic, we have only one security in the clinic. And it makes me think the clinic is quite ignored regarding security issues. Because if there should be a security throughout the day and night, why should the clinic have just one who can't definitely stay throughout the day? So I want to respectfully ask that leadership reconsider that. Thank you.
Good question. Staffing norms for security people.
Thank you. I'm Margaret Mary Alakok. Man is a comment. geared towards the first presenter, and it may be a response to the first question that was raised. Throughout yesterday, there were issues pointing towards the need for health training institutions, not the service delivery areas, to look at specialization instead of general work that we do. And that also tippets into the 80-90 management. So as training institutions, we need to match what is needed at the service delivery area. We heard of one ambulance, one district. We heard of doctors that can specialize after 1 year or 1.5 years. What about the nurses? Those doctors and healthcare team, they need nurses in those specialized areas to work with them. So we have overtrained the general nurses, the midwives, and it's most of these, the auxiliary nurses that are at home that are not employed, to the extent that some facilities don't even need them. So can a health training institution also rethink to match up with what is needed? The disease burden now, what do they need? All age, infectious disease, pediatric nursing, neonatal nursing. We can collaborate with the Ghana College of Nurses and Midwives to see how these training institutions, we can also bring up specialized nurses that will match up with what we need now. So majority of those that are at home could be the general nurses, the auxiliary nurses that are not employed. Thank you.
Thank you very much. Specialized nurses. 2 more.
Thank you very much. I'm Solomon Pankpe from Sabuba Asamsa God Hospital, currently at Nakpanduri. The first presenter presented a lot of, they talk about nurses, they talk about midwives, and I'm a physician assistant. I've not heard anything about physician assistant. And just recently, they've employed a lot of nurses, and with the physician assistant, it looks as if we are being neglected. So what are we doing for physician assistant? Thank you.
Remember, we physician assistants, we do video. Yes. Bishop has a very innocent question.
Thank you, innocent indeed. I came late. Anyway, I was 10 o'clock, so I didn't come late. But for the presentation, just a few seconds, somebody touched on other staff who have been sitting at home for some years, and then after some years, they are brought back to start working. Is this country really looking at health infractions as far as their training competence, especially when you stay at home? What I know outside Africa and so forth, after 2-3 years, you have to go back to school. But somebody's as a nurse, you are trained, you are sitting home for 3 years, and they are just employed to go back and take care of us. It's a very serious issue that the governments have to look into. My second point is about security. I was happy to hear, I don't know your rank, so.
COP.
COP. Oh, Mr. Bloch, thank you. Confidentiality. When it comes to disclosing certain confidential issues to our security personnel, they disclose your identity in some cases. How can we trust our security people? Thank you.
Good questions. Okro mouth security people. Any more questions? Can I? Very last one, yes.
Thank you. I'm Beko, Dr. Beko. Dr. Entry, in his presentation, he mentioned the care of the caregiver. And I was wondering, what is the roadmap with regards to the care of the caregiver in the Chag fraternity? You can look at that. The other aspect, the second question is, you mentioned that Chag are not to embark on strike. Yes, meet, but have an we push for an LI support for this stand, because I don't know, I'm not a legal person, so I don't know, should a legal tussle arise with regards to our position and the fundamental right of the worker? How do we juxtapose the two?
Good question. I will now invite first James to answer the questions that were posed, then COP retired.
Thank you, Dr. Chair. Yeah, I would like to thank all of you who asked few questions. Some of them are comments, which will have to strengthen the process. Now, your question on employment and then the need. We have unemployment because government is the main source of employing health workers. So at the end of the day, you have trained to meet the need, but government is not able, because of fiscal space, to recruit them. So we have all of them. They are not only nurses. People think they are auxiliary nurses. No, it cuts across over 68 categories of health workers in the country. And even the nurses, we employ them frequently. But when you look at other areas, yesterday Dr. Dua presented allied health categories. They have not been employed for so many years now. They are not, we have trained them, the need is there for them, but because the skill makes us focus on doctors, nurses, and so we tend to neglect them. That's why Dr. Dia was saying that move beyond doctors, nurses, and look at other allied health categories. So one is the fiscal space by government to recruit them. That's why we suggested other funding mechanisms that can absorb them. So if we can create other decent jobs, health-related jobs, which will not be the role of government, but the role of private sector, and government recognize, they can recruit some of them, and then they will be doing the work for us. Now, tied to there was a question on unemployed, and somebody raised the physician assistants are part of the health workers. They are considered key part of health workers. So nobody can downplay physician assistants. That is why we said that the focus has been doctors, nurses, so let's shift to include all others. So physician assistants, you are part of that. Now let's look at specialization. So Coeti President, thank you very much. That should be the focus, the need of the areas that we have to focus. And that will fit into health training, development plans and strategic plans, so that our health training schools, like what my brother Mr. Nyante started doing, to look at the areas and how can we also fuse the health training into the colleges so that they can also inform the nursing and midwifery college to focus on specialized areas. Now rethink we have care for the caregiver. It's something that we are advocating, and I know Chag will take that up to see how they have a mechanism, roadmap to cater for care for her caregivers. Now, I said in Chag, we don't have to go on strike. That's a moral principle. Making it legal, I leave it with my brother, Dr. Yeboah, and his team to look at how best we can make it legal. But my point is, we are building a resilient health workforce. That's the fundamental. That's what we are doing. And if this resilient health worker is to help us absorb shocks, and now we have shocks, and they are also running away, then we have not built the resilient health worker. So, Dr. Yeboah, that is my basic principle, that is resilient health worker. When we have shocks, they must be there. So other health workers are on strike, and you also join. Then we are not building a resilient health worker. So it might not be necessarily legal, but moral principle, the anno fati principle, the faith and our belief, and as Christians, can be enough than even looking at the legal principles. Thank you. I hope I have addressed all the questions.
Okay, thank you, Mr. Chair. Dr. Chair, sorry. Yes, somebody asked a question of what can be provided to the private security personnel when they are on duty. The law establishing the private securities, the security companies, does not allow them to bear firearms. So they cannot bear firearms while on duty. But they can use other accessories like batons, or even now we have tasers, which I think they are allowed to use. But firearms, no. We haven't gotten to that stage yet. I know in certain jurisdictions, private security companies are allowed to bear firearms. Even in neighboring Cote d'Ivoire, then the private security companies bear firearms, but in Ghana, no. Then somebody talked of only one security guard in a clinic. Yes, I stated in my presentation that you should collaborate with the local police. Wherever you are, if there is a police station there, see the officer in charge, tell him your problem. Yes, if he doesn't have the numbers to maybe post somebody there on duty, at least they can be coming to patrol around the clinic, which will help to ward off criminals. Now, Your Lordship talked about police officers who tend to disclose the identity of their informants. It is a misconduct. It is a misconduct. When I was head of CID, I don't know whether the person disclosing the identity is a detective or a uniformed policeman. Detectives are given training in addition to the basic training that all police officers receive. And during that training, they are told how to treat informants and not to disclose the identity of their informants. So if even they are privy to information from an informant and they go to court, maybe they are testifying in court, they are given that privilege not to disclose the identity of the informant. If there is a need for maybe the informant to testify, it has to be done in camera because of the danger it will pose to the life of the informant. We handled the case, and the informant, the one who gave us the information leading to the arrest of the person, at a stage we even gave him put him in a safe house. We took him from the locality where he was living, because he was living with the perpetrator of the crime in the same neighborhood. So we took him out, put him in a safe house, and later, when we realized that he was safe to go, we gave him money to rent another place so that he moved from that locality. So it is a misconduct. So when it gets to the authorities, to deal with whoever does that. I can talk for myself. When I was head of, anytime such a report is made to me, what a detective doesn't like is to be reverted. The head of CID has the power to revert detectives. He appoints and reverts detectives. So if you say just by way of signal that this man has been reverted to uniform, and then they'll ask the officer in charge of welfare to repost him. So he has to go for a refresher course before he'll be reposted. And he will lose the clothing allowance which detectives take. And what I used to do, I'll revert you and not post you out. We will revert, and I'll talk to my colleague in charge of uniform, welfare, not to post him out. There was one we reverted at in a station in Accra. And he came weeping. That what pained him was that he was not posted out. He was a sergeant. And being a detective, they will be wearing coats and with tie. So people refer to them as Mr. And with the police, it is only senior officers from the rank of assistant commissioner who are referred to as, are addressed as Mr. The others are addressed by their ranks. So the next time, he was posted on guard at a bank. And people saw him bearing firearm in uniform, bearing a firearm. So they said, oh, so this one is only a sergeant. So these are some of the ways we punish them for their misconducts. So once it comes to the notice of the authorities, they'll deal with the person.
Yeah, Doctor, I think there was one question from Bishop about health workers unemployed, stayed at home for many years, and immediately we get them back to service. That is no. I think the ministry must have a policy on that, because you cannot be trained for so many years. You don't practice for 3 years, 4 years. Then immediately we take you, push you to the hospital. I think it's a very good observation, and then we want the ministry or at Chag, and we can have our own policy on that, so that we can do about 6 months training before we engage them in in practice. Thank you very much for the observation, Bishop.
Let's clap for our two. Yes. Father has a question.
Thank you, Dr. Chair. I think the issue on strike has not been answered. We have always said that Chag institutions do not embark on strike. This is a convention that we have always held up to. The recent strike action by the biomedical engineer scientists, on our platform, more than 90% of our facilities kept saying they are on strike. I think there should be a definitive statement. If we are for strike, all of us should know. If we are not for strike, I think we should know. If we don't have any legal backing for what we say, there should be something on the table for us managers to rally around so that we don't hold anybody responsible. But if we are not for strike, we should have that authority to rake in our employees that we are not for strike. Otherwise, all of us hold ourselves to ransom. I remember it has been said that the government takes responsibility for the salaries of Chag institutions because they know in the event where the public facilities are on strike, we would hold the fort. But if today we are all on strike, what is the basis for them to keep giving us what they do? So my simple question is, there should be an answer, a definitive statement from our leadership. Thank you.
All right. Let me invite James to... Is it related to the strike?
Yes, please.
Very quick one, please.
Okay, very snappy. My name is Paul Tia, the island city, Ashankragwa. My question goes to go with this strike as mentioned here. Recently, our medical laboratory professionals workers union embarked on strike. And unfortunately, they went along with non-mechanized staff whom various facilities use the internally generated funds to pay them.
I like your snappy question. Have you finished?
No, please. So,
oh, be snappy. Yeah.
My question is, do I have the right or can I bite the non-mechanized staff seriously? Thank you.
All right. James.
Hello. 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 I think this is a deep question. That is why the room is. So before I say anything, today one of the sessions that we have is sharing best practices. We have 4 facilities that are going to share with us their best practices on HR and quality. So at this point, I will invite Dr. Cranton to share with us, yes, on his, just in response to this question, the issue of strike and how Pentecost has handled the issue. Then I will come in with my answer. The mic. Is the mic?
All right, thank you very much, Dr. Chairman. I think about 2 or so years ago, when the nurses had their strike, my facility was physically trespassed because the then task force came on-prem to force my nurses to go. It was out of that experience that we had some engagement with some of the union leaders. But what came out of that is that we as Pentecost Hospital Medina, we have our own internal condition of service. And in that, we are clear that we are part of Chag. And so strike is out. So whoever we employ, we give you the condition of service. You study and you sign a declaration form that says that you're okay. And so beyond the unions, we have a direct relationship with you. Signed. Well, and I think that is powerful enough to engage you when you violate your own, document. And the second aspect has to do with the question he asked. I want to commend my head of lab who is here, that for Pentecost of Medina, they didn't participate. And Ima is here. Ima, that is commendable. But before then, I met them. And I remember I was telling both the IGF and then GOG staff that don't be in a haste to join, because the first question I'll ask you as a manager is show me your card. Because some of you are on IGF. As far as I'm concerned, you are not a member. You are not paying dues. So on what basis are you going on strike because I'm going? And even those who are on GOG, you have to give me evidence that you really belong to the association or the union. But somehow, by the grace of God, my team leader for the lab is excellent. But I think the issue is that we need this of safety for all of us. If Chag would join the we have a challenge. I think that whether legal or moral or ethics, we must stand strong and have a community and be able to engage so that whoever is joining us, I mean, Ghana Health Service is there, teaching hospitals are there. If you choose to join us, then join. If not, there are other avenues. Thank you.
Thank you very much, Dr. Cranton. I think it is clear, isn't it? Yesterday, it's not clear. Okay. So, you know, we have decentralized leadership in Chag. We'll open the debate later on for you too. But we have decentralized leadership in Chag. Your appointments come from the facility level. And it is the point where the managers should institute all the things that you need to. Yesterday, if I understand from Esquire, Director J, what he's saying, he says, the legal laws are there, the policies are there, but when you sign local contracts, then you must interpret the local law very well. It is there, and you are signing local contract which says that I understand this, I am agreeing to this. So once that is there, if lawyer is here, he will speak about it. The local contract, I think, takes preeminence. That is why you have signed. And I like what you said, that there are options. So once you know that these options are there, but here if I go, I can't do this. I think that's what we need to go by. Thank you.
Thank you very much. So in Chag, we have 11th commandment. Thou shalt not go on strike. Thank you very much. We've had a very stimulating session, and on your behalf, I want to thank our two presenters. We started with my brother James. I had known James as an HR expert, but now I have to change my caricature of James. He's also a philosopher, quoting Einstein. And he talked about the three dimensions of his topic, the Holy Trinity. How do you build resilient health system, quality, and financing? I'm picking on this because he made some very important points. I wish our policymakers were here. That without health workers, we do not have health. For most of our politicians, when they talk about health, the next thing you hear is hospitals. We've built so many hospitals. We should move to the narrative where when they talk about health, the first element they should talk about is health workers, not the number of hospitals you've built. So that was a very good. And he also added that health workers can help grow the economy. We saw that in COVID, how health grounded the economy. He bamboozled us with a number of figures, so I want to just simplify it a bit for us. He said, in order to achieve the SDGs in Ghana, we need to train in the next maybe 10 years, 500,000 health workers. 500,000 health workers. And currently, we have potential to train 78,000 a year. At the moment, we are training about 55,000, but we have the potential to train 78,000 a year. So production is not our biggest problem. Our biggest problem is how do we employ them How do we retain them? How do we motivate them? How do we keep them? And the other point he made is that the quality of care depends on the quality of health workers. So we need to care for the carers. And a lot of his recommendation was to do with what financial mechanisms are needed to make sure we are able to do that. So he mentioned things like the fiscal space, manage migration, community financing. And he ended by talking about the need for us to rethink the skill mix. Yesterday we heard from Akusa that health is a team sport. And yet we don't behave that way. Anytime we talk about human resources, we talk about number of doctors per population, number of nurses. We should rather be talking about the team, not the individual tribes in the profession. So that was a very good point. And the point about as our population ages, we need to rethink the type of health workers we want, or the type of health care we need, and the issue of specialized nursing. So very, very good points by James and the discussion. Then we had a good lesson on security by our top security couple. Most of you may not know, but COP Ablo for many years was Director General of CID. He's also been Director General of Legal and Prosecution, Director General of Special Duties, Director General of Welfare, President of the Police Officers Mess. So he's a really experienced security person. He looks gentle, but he can be tough. So, and he did mention that because of our open door policy, we need to take security very seriously in order to protect not just ourselves, but property, occupants, and visitors. And I really like the 5 Ds. Deter, detect, deny, and delay. And he gave some takeaway messages on what we can do on our facilities, including increasing surveillance 24 hours, 24/7. Parking lots to be well lit. We should limit available entrances and exits. Most of our hospitals, there are so many entrances and exits. Use of ID, increased site security staff, access control, drones, electronic entrances, and cyber consideration. And he taught us a little about security, that criminals can help you. So criminals can be helpful. But he hinted that our greatest security risk is our staff. So we need to pay attention to staff, make sure when we employ them, we've gone through all the security checks. And ended by saying, if you see something, say something. I will add, if you see something, say something and do something. So thank you very much. We've also learned a little secret that in the police service, one punishment is when you are not allowed to go out. And you are posted to the bank on guard. That is a punishment. So you understand why going out is good for the police. So in police, when you are not allowed to go out, your revenue, you know what I mean. Thank you very much. Thank you, COP.
Thank you very much. Thank you very much. Thank you very much. Thank you very much. Hello. Hello. Thank you very much. Hello. Hello. Hello.
Hello. Test mic 1, 2.
Hello. Hello. All right. Thank you very much. That is coming from Savior Church Health Services. Ladies and gentlemen, this morning the room is packed. The room is heavily packed. And I have so much confidence in this country. We have we need a new mic, please. Okay. All right. So the room is full and heavily packed, so we will start. If you can see from the high table, it's heavy. Just by way of highlight, yesterday we had working session. We had somebody from the ministry giving us USC roadmap and the contributions that Chag can make. Presented Chag what we have been doing in terms of the USC by way of access, financing, and quality of care. And then we had somebody address us on energy issues, which is the big elephant in the room. But we brought him because many years ago, we had hello. So we had investors from Norway. They came around wanting to offer Chag solar energy for the whole of Chag. And by way of due diligence, we went to the Energy Commission. And then when we left the office, we were called that, wait, And when we were presented with the figures, it was scary. It was not conducive. And so the man advised us, and we stopped. And if you are aware, he's the one who did the energy efficiency, free changes for energy efficiency. I think he presented us some vital information. I hope that you go and develop protocols. And then we have professional presentation from Professor Kusa and all the others. Today, we will continue. So for this session, I would like to introduce the chairman for the occasion. The chairman for the occasion, ladies and gentlemen, is the chairman of the National Vaccine Institute. From 2020 up till now, he's been the presidential advisor on COVID-19 and in many ways contributed to our success in COVID response in this country. He retired 2017 from WHO, rose through the ranks and became the Deputy Director General of the WHO. That is the highest office in WHO that any Ghanaian has ever occupied. Until going to the WHO, he worked at the Deputy Regional Director of Ghana Health Services and was in charge of communicable diseases. He also worked as District Medical Officer and then Director PPME for Ministry of Health. He is known to have taken very tough decisions, including deciding on how partners should support this country. The most important part of it is that he worked within the Chag system as the medical superintendent or medical director for Offense Catholic Hospital. He's a product of University of Ghana Medical School, London School of Hygiene and Tropical Medicine, where he also taught as a lecturer. And then also went to Prempeh College. Today I'm not talking about schools. But ladies and gentlemen, before I introduce him, let me also say that he has a prophetic ministry. If you remember in 2018 when we met in Sunyani, he said, Chag will be better, bigger, and richer. Today, Chairman, we are better, we are bigger. We are yet to see the richer. No, we will. As two of the prophecies have come, the third one will follow. Ladies and gentlemen, I introduce to you Dr. Anav.
It's gone now. Hello? Yes. It goes and it comes, so go ahead. I was saying I'm grateful for you the ceremony. I have been impressed with the innovation that the organizers have introduced to this year's conference. This is a 2-day conference. And in fact, it started yesterday, and today is the final day. But today is also the opening day. With this development, I will not be surprised if in your future conferences, you start with your closing ceremony. And end with the holy. Praise the Lord. I've had hello. 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 I think the witches don't want me to speak. All right. A suggestion is that the microphone, so we'll be entertained by the singers while they try to fix the microphone. Yes, so they are going to sing it. All right.
Hello? Yes, hello. Yes, hello. Okay. Never. Yes, hello. Yes, okay. Yes, hello. 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 Yes, hello. Hello. Okay.
Hello? 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 Yes, hello?
Hello? Hello?
Thank you very much for your patience.
Yes, hello.
I've been privileged to work with Chag, as you heard, but I've also worked with the Ministry of Health. And 30 years ago, not many people in the ministry headquarters knew about Chag. Anytime you mention Chag, the usual question is, what is Chag? Today, if you ask the same question, people will label you as are you the Holy Spirit in Jerusalem? And this speaks volume about the transformation that's taking place in the health sector, in the ministry and in Chag. And I would like to pay special tribute to the ministry, but also salute Chag institutions, your leadership, the Secretariat, Board of Trustees, supporters and sponsors of Chag, both past and present. I must say I'm also impressed with the participation, the broad and inclusive participation at this conference. In the past, Chag conferences were attended by mainly leaders of Chag institutions. So a large part of the conference was lamentations and insulting and blaming government. What we were doing most of the time at our conferences. And that reminds me of a story. This is a true story told by President Lula of Brazil. Before he became president, he was a trade union leader. Then he became leader of the opposition party before he became president, and he went to prison and is back as president. He said when he was a trade union leader, anytime there was a problem, you blame the government. Then he became opposition leader, and anytime there's a problem, he will blame the government. I'm happy that Chag has matured from an institution that was always blaming government to an institution that seeks to work side by side and with government, and not just the Ministry of Health, but all government agencies, as we saw yesterday and we're going to see today. Chag works very well with academia, private sector, NGOs, civil society, external partners, professional associations, and trade union. Chag is not a perfect institution. It has its own tribalism and politics, but Chag is a strong and solid institution. It is therefore my prayer that Chag continues to grow strength to successful. Assalamu alaikum. Thank you.
Thank you very much, Dr. Chair. So we have some important guests with us here. Let me introduce them once again. On my left is a team from Pharmacists, Dr. Koforidua, who has come all the way from Netherlands. Dr. De Graaf, who is the head of Safe Care Global. Dr. Henry from Tanzania is the head of Tanzania. We have Oswald from National Health Insurance Authority, PRO. We have our board members here. Chief Director will do the introduction, so let me skip this one. I have Mr. Nyante, Felix Nyante, a past Nurses and Midwifery Council here with us. On the high table, we have Mr. Franklin, who is the head of Workers Union here. We have Heather Robinson. So pleased to have you in our meeting. As you know, USAID supports Ghana very heavily in many areas, and she is the head of HIV programming. Heather, you are welcome. We also have Dr. Bano, Philip Bano from HEFRA. Yesterday, you were told that without HEFRA, you cannot proceed. So it's the single most important institution here now. He is here. We also have a household name who needs no introduction, Dr. Maswell Entry, a global icon, country director for Pharmacists Ghana, who also went to a very good school, Prempeh College. I'm resisting the temptation, but I can't. Our board chair will be introduced by our executive director, and then the other big end as well. I will introduce them appropriately. Ladies and gentlemen, let me at this point invite our own. So he's worked 30 years in the health system. He understands from A to Z of the health system, having worked from different levels. He's an expert in leadership and governance, social and health policy and public health. He is by calling. There are many of you here that he has taught in the university. If we travel around with him, we see many people saying, you taught me research, you taught me research. And I have benefited immensely from his leadership. You can never get tired when you work under him. If I show you my WhatsApp, it's full of motivation. Excellent. Carry on. Carry on. So if you see me, he gives a lot of motivation and teaches. So he's also a transformational leader. If you are aware, we have sister organizations in the African continent, 42 of them. He was the president for 7 years, and under his leadership, ACHAP transformed, became a very notable organization with multi-million-dollar grants. Ladies and gentlemen, wherever he's worked, the organization has changed. Holy Family, Techiman, God so diocese, and you are aware of Chag. As the chairman said many years ago, if you mention Chag, Chag was nowhere. And now we are here. I read the book by Apostles and Kusna on 5 practices of exemplary leadership. He interviewed 35,000 people across the world and found out what are the common 5 practices. The first one is model the way, inspire a shared vision, challenge the process, enable others to act, encourage the heart. Our leader models the way, so we know where Chag is going. Most importantly, he enables others to act. And that is why I always stand in front of you. And he encourages the heart. So, ladies and gentlemen, I'm pleased to introduce to you Dr. Peter Yabua, the Executive Director of Chag. Before he takes the stage, let me say he's a product of London School of Hygiene, London School of Economics, and Royal Tropical Institute. I'm not mentioning his local schools.
Dr. Apostle Dr. James Dia. Now I know you very well. Dr. Dia, many thanks for the kind and gracious introduction. For once, I thought it was obituary, or it was a prelude to a campaign ceremony to launch a presidential campaign. Thanks so much. Our distinguished chairman, a global icon, someone who represents knowledge, humility, and transformation. Your Excellency, Dr. Samwaba, we are grateful for accepting to chair this great occasion. When you have a former Director General of World Health Organization spending 48 hours pro bono, it is the love and care he has now that we are grateful. Chair, before I proceed, let me introduce the members of my board who give me direct appointment, who decide whether I will stay at the Chag Secretariat or not, and therefore I don't go on strike. Because my promotion and progress depends on them. Our board chairman is Dr. Elias Sori. Dr. Elias Sori is an accomplished public servant, almost 40 years, and a former at the Catholic Health Service Trust. The Catholic Health Service Trust. Moving on, right, we have Mr. Enoch Osafo. He is the Director, Methodist Health Services. You know, the board could never have been complete without the presence of a holy Reverend Sister. We have Reverend Sister Veronica. Sir. We have Mr. Emmanuel Quenin, a chartered accountant, a distinguished member of the accounting world. And then we have one lady I would like to describe as Her Excellency, Madam Margaret Mary Alako, the president of Kuwait and principal of Holy Family and MTC. Then moving on, there is a very fine Kumabwaji. First, let me thank Dr. Abwaji for suspending several engagement assignments. Even this morning, he said for the love of Chag and for the fact that Peter and Patrick are saints in heaven, he will come. Thank you so much. Dr. Masulanchi, my friend and brother, and a strong supporter of Chag, country director. Honorable Franklin Usuansa, General Secretary of Health Service Workers Union, Madam Heather, US Said, and a gentleman of regulation, Dr. Philip Bano, very fine so. Let me recognize also a gentleman who worked at all levels, first as a nurse educator, regulator, and policy maker, Elder Felix Nyante. Elder, thank you very much for joining us to share our experiences. There's one particular board member here who is missing. Lawyer Joe is not present here when he comes. Where is Lawyer J? Okay, very good. Lawyer J will be coming. There's also another board member here. So nice and cool. And he brought the melodious singers from Savior Church Health Services, Mr. Kwaku Frimpong. God. Most of all, friends, honored guests, let me acknowledge the presence of the frontline leaders, servants, and stewards of our healing ministry. Those who make Chag better, brighter, and prophetically richer. The staff here in Gede. Friends, I salute you for your resilience and presence. I will not forget the media and the police men granting the security. Our distinguished chairman, in the normal course of events, the entire Chag fraternity every year to account for our stewardship in promoting Jesus Christ Healing Ministry. 4 years ago, we were very much obliged to suspend such special events in response to the government's call for all of government and all of society response to the COVID-19 pandemic outbreak. Indeed, under the auspices of several actors and friends, we came together to ensure mitigate and prevent COVID and its effects on our health system. Indeed, throughout, we supported government in all the COVID response actions, from social mobilization, risk communication, case management, surveillance, just to ensure that as reliable partners of the health sector, we cooperate and collaborate with government at a time of need. Thankfully, by 2022, we tested 30,711 people. All our institutions, facilities, most of the time hospitals became case management centers and admitted 7,515 positive cases. We managed all of them. Sadly, we lost 209 people. Dr. Che, at this point in time, there were frontline leaders. One gentleman who was the first victim of COVID in his attempt to promote the healing ministry of our Lord Jesus Christ. Therefore, with the concurrence of the chairman and friends, and united in grief and solidarity, may we stand in a minute silence, recognize the loss of Dr. Harry Osu Boating, a physician specialist at SDA Hospital, Kwadasu, who was the first victim.
God Almighty Father, we thank you for all our staff. We thank you for the administration, special way as we celebrate this day. We call to memory your sons and daughters who worked with Chag. And during the COVID, we call to eternity. We commit their souls into your loving and merciful hands, and assurance of sympathies for their faithful family members and also for Chag. Bless them and grant them eternal repose. In Jesus' name we pray. Amen.
Amen. Many thanks, my Lord. On that sober note, we shall proceed with renewed spirit of service and stewardship in the healing ministry of our Lord Jesus Christ, aware that our souls shall always rest in the bosom of Abraham. Dr. Chair, friends and colleagues, it is often said that coming together is the beginning. Keeping together is progress. Working together is success. Yes, by sticking together in and out of season, we have demonstrated that we may be vulnerable as a people, but we are not fragile. We always bounce back. Today, in a spirit of resilience and commitment to our timeless mission of providing the essential health needs of the people in Ghana and being a reliable and trusted partner of the health sector, we meet here today to review our collective journey on the way to attaining universal health coverage. We are united in our shared mission of ensuring that everyone living in Ghana timely access to the highest quality of health without financial barrier at the point of need. Indeed, we all agree that UAC, united, or let's say universal health coverage in health, is a strategic priority and a shared responsibility for all. Way back in 2020, at the dawn of COVID, our country launched a roadmap to ensure that all of us living in the country will have access to equitable healthcare without any barrier. Chair, we are aware, as we learned yesterday, that UAC has three main pillars: access, quality, and financing. May I share some of our contributions so far? Chair, friends here in Gadet, every year, the entire Chag fraternity provides healthcare for about 6 million Ghanaians in our country. And we provide, and so Pharmacists, Chag, and Ghana Health Service have been assigned a special missionary duty to ensure the institutionalization and nationalization. The lack of robust and sustainable quality systems and structures mean that we are failing to meet patients' needs, health outcomes, and by extension, loss of patient trust and confidence in the entire health system. Indeed, the moment patients sense that quality is suboptimal, it is a recipe for loss of interest, confidence, and it leads to underutilization of our services. Chair, it is also clear that equitable quality healthcare delivered by highly skilled, competent, and dedicated health professionals, or healthcare workers generally, is essential to meeting the promise of the heaven of universal health coverage. Chair, we are also experiencing the rising spate of medico-legal issues. It's very clear that most of these cases, as we've seen, are avoidable. And we are aware that the cost and consequences of suboptimal care is a threat to the entire health system. Indeed, for Chag, noted for excellence, noted for value-driven healthcare services, where everybody will see Chag as a sanctuary of health, hope, and healing, we must be apostles, disciples, and champions of quality healthcare. It is clear, Chair, that we need quality health services that are delivered with compassionate, focused, compassionate healthcare workers who demonstrate empathy and who are always interested in meeting the health needs, preferences, and values of our patients who need our care. Therefore, for this particular conference, we recognize the need to embrace a culture of ongoing learning and adaptation to enable us address common challenges and mitigate the risk of suboptimal health services. Therefore, this conference is aimed at the following. First, we convene here together to celebrate already. Most importantly, we want to identify and document relevant issues and challenges, evaluate our collective experiences, share lessons learned and best practices across the entire Chag network, and most of all, spread the gospel of safe care beyond the frontiers of Chag, national health systems, and even global health systems. In essence, we seek to profile and reposition health services quality and human resource for health that we recognize as integral priority for higher impact on our journey towards universal health coverage. Clearly, Chairman, friends, universal health coverage, the word universal itself, is an expression of inclusive development. And it's also a call for social solidarity, ensure active inclusion of all key actors. We believe that they are core values that are ingrained on our journey towards ensuring that within the next 6 years, by 2030, we achieve universal health coverage. We believe strongly that with our full and active support for this journey, UAC will not only be aspirational, but it will be a lived reality and experience in our generation. Therefore, this conference is not only about fraternal bond, not only about networking, it's a call for intensive, intimate partnership of stakeholders, from policymakers, from all angles. May I express my deepest appreciation to our honored guests, friends here in Gadet. And for the first time, we are seeing intimate connection between academia and the healthcare industry. The disconnect has been fatal. We are pleased to have the Pro Vice Chancellor, a renowned researcher, who will give his perspective, research, findings, and everything beyond the methodological rigor and robustness that academians are very much fixated on. Will be giving us practical solutions and connections to reform our journey towards universal health coverage. Prof, we are grateful. The disconnect from industry is failing you to applaud, to give proper applause for us. In our journey, over the past 4 years, we have benefited from partners, pharmacists. We have benefited from cooperation and collaboration from the Ministry of Health, Ghana Health Service, from HIFRA, from Labor, from everyone, and most of to invite my Lord Bishop to be in. We are in the eastern region of Ghana. All the bishops. Let me tell you a secret. Don't go and tell him. I beg you. Otherwise, I'll go for confession and absolution. Bishop is noted for specificity, clarity, discipline, and insistence on the finest champion of quality. With standing applause, may we welcome His Lordship, Most Reverend Joseph Kwaku Ajekum, my Lord.
Please sit down. I hope all that he has said about me, with all these portfolios, also came with salaries. I never received any salaries. Before I address, I want to mention, as he said, that I was in charge of health. I traveled with the Catholic Health Directorate across the country because at that time, everything was in Accra. And I said, why don't we go to the field and see what is happening? And so we set out to travel north, south, east, and west. And I remember one of such travels, we flew to Tamale, and from Tamale we took a vehicle, went to Damongo, West Gonja Hospital, and went to Kalio. We went to Wa and spent the night there after official visit to West Gonja Hospital. And then we went on to Wa to spend the night. In fact, we spent 2 days. And the next day, after the meetings, we continued to Kalio, went to Jirapa. There are 2 hospitals. I remember one traditional, the hospital, within the hospital context, there is also the training institution, one the traditional one, then the Orthodox one. And went to Nandom. It was getting late. We drove. Our driver, I remember Jonathan, a crazy driver, but a very good one. From Nandom all the way to Viaga, and it was in the night. Very risky. You drive 20 kilometers, you don't see any community. So we came to a customs port, and he said, Bishop, why are you traveling at this time? I said, well, we want to see our people, what is happening. So from Viaga, we went to Bolgatanga, we went to Zoko, and visited all the institutions, then came back. We've gone through Kumasi Diocese, all the way to Obuasi, Isansi Bontefufu, and there's one other, I can't remember, one clinic. When we went there, we were using 2 vehicles. And when we got there, it was an emergency case. So I asked that they should take the patient to Obuasi. So all the rest of us, we had to squeeze ourselves into the remaining vehicle. It wasn't easy. We've gone to the western region all the way to Asankagwa. From Takrady, we went to Asankagwa. In fact, on the way between Asankagwa and Yoso, I was so annoyed with the Galamsey, let's go in the mining distraction. And it was in Asankagwa, that we had a good lunch. And the lunch was between fufu and apesie and kontomire. And I said, I'll eat apesie and kontomire. Those who ate fufu and others, they didn't have it. Dr. Nita, is she here? Okay. She was carrying our first aid box. So we go to the bishop in Yosu. We spend the night with him. And before dawn, I started running. Not knowing Dr. Anita was carrying our medication, was equally running. So anyway, in the morning we had to go for church service. And to be honest with you, it wasn't easy. So after the church service, we were all complaining, those of us who ate apesie and kontomire. Then we continued to close the border. And then, what is the one close to the border? Yametra. Before we got there, Dr. Anita was almost admitted because her situation had developed more serious. I said, are you carrying our medication? You should have taken all the medicines and then you would have been Dr. Patrick, please, I hope you didn't hear me. So we finished with that and we went to the Volta region and visited the institutions over there. In the Volta region, from Jasikan, we went to Chinderi. In fact, we were late in crossing with the boat, so we had to wait for the next crossing. From there, we went to Nkwanta. Nkwanta was not so happy to see what some ministers had done. We had a Catholic hospital there many years, and he went and put another hospital next. Waste of resources. I criticize it, and it's not necessary. You know, we have a very good hospital. Instead of putting the resources to, increase and improve healthcare, he put another one side by side as if there's competition. So anyway, we finished and we came back. I can tell you the stories. Why am I saying all these things? My whole aim was to be able to see where all few Chag members are spread, and especially accepting to work among the deprived people. Thank you very much for this, your work. I'm not one who has so many of these preambles. Permit me to just address and stand on the existing protocols. The chairperson, Chag board trustees, distinguished guests, Chag members, brothers and sisters in the health ministry. With pleasure and thanksgiving, I am pleased to welcome you to the Catholic Diocese of Koforidua and the Eastern region of Ghana, a place well acclaimed for hospitality, peace, and friendship, and at the same time, good flowers. I'm sure you know about that. The flowers are still blooming. My dear brothers and sisters, at the dawn and peak of the COVID-19 pandemic, the entire nation witnessed and benefited from your commitment, your efforts, and sense of duty that enabled you to serve others in love and solidarity, even putting your own lives at risk. To re-echo the voices of gratitude, all the personal and professional sacrifice invested at that time, and continue to do so daily in promoting the healing ministry of our Lord and Savior, Jesus Christ. Such spirit of fortitude is what consummates this mic, which consummates our character and commitment as Christian health workers in the health sector. You may have been specially rewarded, yet But be assured of God's amazing blessings and possibilities for you to continue to do the sacred work of saving lives, bringing health, hope, and healing to families and communities. And now to my main message. Text to the conference theme. Mr. Chairman and distinguished invited guests, as Christian health workers, we are united in service around two main timeless principles. First and foremost, people who need our care should feel cared for with the highest professional standards for holistic service provision. As people of faith, we are inspired to bring health and healing to the greatest number of people, alleviate their pain and suffering, care for the poor and vulnerable anywhere a need is identified by us. Secondly, in such the same, healthcare workers should also be cared for through appropriate recognition of service, protection of proper working conditions, right skill mix, so that the right to care could be a universal right and reality for all. Therefore, the conference theme, and I quote, Ghana's journey towards universal health coverage, addressing health care quality and human resources challenges, reflects the core mandate of our vocation as health workers and highlights our collective roles and responsibilities as servants and stewards of Christ's healing ministry. Most importantly, the theme is a reminder and special invitation to formulate feasible strategies and solutions to evolving demands for quality in healthcare and appropriate human resources for health development. In essence, the conference theme highlights two indispensable assets of a responsive health system. These are quality of care and motivated, productive, and reliable health workforce. A call to action. Health care service provision. Mr. Chairman, distinguished guests, we need to harness utmost quality standards for tangible health interventions and outcomes. In this case, we should always explore innovative projects and programs to reduce the spread of infectious diseases, address the debilitating effects of non-communicable diseases, and preventable maternal and newborn deaths, and enhance the quality of health and well-being of all persons in need of health care, especially in our Chag health care institutions. Chag health training institutions. Our health training institutions should ensure excellent, professional, and ethical with moral formation of competent and of health workers committed to the legitimate health needs and preferences of our country. Our Christian ethics, values, principles, and non-strike conventions in pursuit of universal health coverage. I wish to reiterate, healthcare workers need missionary reorientation and be made to accept postings to needy environments. I talked about this not too long ago. I had somebody calling me from outside the country because his relation had been posted to one of the Afram Plains institutions. and thought that the place he or she also could come. He was not happy. Unions. Now they are in negative position to some of our Chag members so that they become, as it were, constrained. Somebody is the regional so or this and so forth. So when there is a strike, since he or she is a leader, or she will have to, as it were, promote it. Is that not it? I'm not hearing. Are you Chag? Are you here? So please, we would like you to look seriously into it. In fact, when the recent strike was in place by the the doctor from Austria who was with me, he was quite surprised. He said, "You want to tell me even they are not taking care of inpatients?" I said, "That's what I'm hearing from, government hospitals and some of our Chag institutions. Inpatients, we have already even contract with them because they are already there. But in case of the outpatients, maybe can be considered. But you all know where we are located. I mentioned some of these names where I visited. And if I tell you some of the stories and experiences that I went through at that time with Dr. Bockel and so forth, it's not easy. So please, we would like to emphasize this. And I want you, please, kindly understand and work with us so that we can give health care to our people. If the government institutions will go, let the people have a place that at least they can be taken care of. It could be your mother, it could be my mother, or your brother, or my sister. For us as Christians, the healing ministry of our Lord Jesus Christ is an integral part of our evangelization commission and portfolio, which shall remain in perpetuity until the Lord comes the second time. Church-state partnership for health. The Honorable Minister is not here, so I believe attaining universal health coverage is a call for strengthening the timeless church-state partnership for health in the interest of all people living in Ghana. And as we consolidate the gains of our past development relationship, we should also try to enhance the prospects of a more viable partnership by ensuring equitable resource allocation to enable Chag to complement the government in the provision of health service and training of professional healthcare workers. So for the Ministry of Health, for that matter, please, the allocation of equipment, don't forget us. I don't think we should come and beg you and ask for it. You know the institution. Why should we be the ones to come and, as it were, appeal for help? Please, if you are sharing the cake, let us all benefit from this. That's the message that I want to give to the government. I am happy to know that a representative, a senior officer from the NHIA is here. And we want to thank you in a very special way. Compared to some years back, I think you are not doing bad, as we say in Ghanaian language. But the moment you add a but, it means there is a problem. Sometimes we hear that payments like, as it were, staggered. You pay me in September, but February, January, or March is outstanding. How that thing happens, I really do not understand. We would think that if there are challenges as the months progress or the years progress, that these issues would be handled instead of paying me in September and then March still outstanding. And sometimes, some of these small clinics and so forth, they don't have the gas to be able to, as it were, go forward. And it looks like some of them lose their funds. Please, they need them. In conclusion, my dear Chairman, at a time of great stakeholders to work together for a healthcare system which truly and fully safeguards the life, dignity, conscience, and health of all, from the child in the womb to those in the last days here on earth. May this conference promote all efforts aimed at building a stronger and sustainable essential healthcare service on the way towards achieving universal health coverage for our people. I wish you a successful and impactful conference. Thank you.
My Lord Bishop, thank you very much for the inspirational message. Another round of applause for Bishop, my Lord Bishop. Ladies and gentlemen, just to let you know, we are streaming live. We are streaming live. Do you know that we have 2 Director Generals of Ghana Health Service here? Former one and the present one. Now, I want to introduce the former Director General of the Ghana Health Services, who is also the board chair of Chag, Dr. Elias. So, the applause is weak. Yesterday we had another former Director General here. Look.
Thank you, MC. Your Excellency, Dr. Chairman. I'm saying Your Excellency as the top person of WHO. He represented not only Ghana, but the whole of Africa. And I'm always proud to be with him at functions. Your Excellency, my Lord Bishop, our invited guest speaker, colleague, Junior Director General, Dr. Abuaje, I'll stand on the existing protocols and address all the others that are here. I am excited and delighted to be with you today. I want to let people know how Chag is formed and who are the board members of Chag. Chag has an ownership, and it is owned by 4 Christian groupings. 1, the Catholic Bishops' Conference. 2, the Christian Council of Ghana. 3, Ghana Pentecostal Council. And 4, Associate and Charismatic Council. 4 associate members. It is the owners that nominate persons they think are good standing to form the board. I was privileged that I was nominated by Your Excellency, who has spoken to you, to be part of the Chag Board of Trustees. So, Your Excellency, I believe that we have not disappointed you. And one of the current duties of the board is to get a leadership that can lead the Chag fraternity and be impactful. And I'm happy that we have Dr. Yepua as one of the products of this board of trustees. Indeed, we are a unique organization. We have been, as Chag fraternity, giving services in rural areas. We are with the poor, and we speak the truth. What is not right, we don't do. The Constitution and the Charter we have mandates all of us to make sure that the healing ministry of Lord Jesus Christ is not tarnished. And that is why we have values. If you go to the military, they have values. Chag has values according to our Constitution and Charter. And if people are to join us, they have to understand that these values are critical and must be followed. So it is not just coming in that things make us to depart from the that we have to accomplish. Not that pressure groups are not important. They are important. But I believe that the pressure groups should also understand that certain unique organizations must be allowed to function so that the system does not break down totally. And I believe the Health Workers Union person here will have to understand why Chag institutions are not encouraged to go on strike. Sometimes you don't need every person to follow in your quest to achieve what you want. And therefore, I beg you, treasure groups, allow us to operate and allow us to be the Christian organization that we are. I believe that we are in healthcare not only money. Well, money is very, very important, but sometimes we have to look at the values that we have within us. I remember yesterday one of the presentations. You have to look at yourself when you want to deliver quality of service. Look at the values that you have. Then you can understand what the values of quality are. If you ignore that, it becomes difficult for your own progress. On this note, I thank all of you being here, and I also welcome you to this conference. Thank you.
Thank you very much, my brother, Dr. Sori. Distinguished ladies and gentlemen, Lordship, the Bishop has other pressing assignments, so he wants to seek our permission to leave. On your behalf, I really want to thank him, not just for his presence and the prayers, but also for his words of wisdom. He welcomed us to Koforidua, the land of flowers, and he recounted his travel across the country, visiting different health facilities with his crazy driver. The lesson I learned from his travel is that anytime you have a choice between fufu and apesi, take fufu. But he made some very important points and remind us that one, Chag must, as Christian health workers, professionalism, excellence, ethics should be our hallmark. And he also mentioned the fact that he believed that health workers must be cared for, properly cared for, and reiterated Chag's position on strike. he made a very good point about the need for viable partnership with government and for fair sharing of resources. And I'm happy that the CEO of NHIA is here. The bishop made a special plea, but before that he thanked NHIA for the progress you've made in recent years. But your payments are not as regular as they should be. So these are the pleas from
to have Head Robinson here to deliver a fraternal message on behalf of USAID. USAID has supported the health system in many ways. Those of you who are the training on maternal health, HIV, TB, and many other areas. One of the staff facilities, Hope Exchange, is being supported heavily by USAID. So to give a message is Heather Robinson, who is in charge of.
I'm you on behalf of the United States, state-of-the-art health equipment like incubators, anesthesia machines, patient monitors, and ultra-low freezers. While specialized services are provided to those who can afford it at a fee, no one is turned away from Hope Exchange. Like Sadia, who went into labor while traveling to Kumasi by bus in 2022. The passengers tried to make her comfortable while the driver rushed to the nearest hospital. Sadia lost a lot of blood. By the time she arrived at the nearest health facility, the Hope Exchange Medical Center, she was semi-conscious, in a critical state, and had already given birth to her baby. The staff from the maternity and neonatal intensive care unit immediately attended to Sadia and her baby, Zaderu. They provided emergency care and saved both their lives. Today, I'm happy to report that Sadia is the healthy, proud mother of a happy and active toddler. This is just one example of the excellent work Chag is doing. Those of you here.
NHIA in the deployment of the clinician, first deployed within the Chag network, and most of the colleagues we work with, I can see familiar faces around. And then scaled up to more than 90% of all NHIA credentialed facilities. In 2021 to 2022, we worked actively with the Health Facility Agency, providing technical support, leading to the development of its licensing tools. In 2022, we were invited by the NHIA to support on analyzing and making meaning out of Yahoo Medical Center, Rabito clinics, and many. That insight is that poor quality kills more people than lack of access. If we look back, it's not too strange. It is better to go hungry than eat contaminated, infected, ampesi with palava sauce. You may die from hunger, but it will take weeks. But if you eat poor quality healthcare, you go to the mortuary faster. That is what that fact sheet says. And it should be a sobering thought for all of us who are in healthcare. In other words, if we cannot provide good quality, people are better off without us. Dr. Chair, we want to salute you and Dr. Patrick Kumabwaji for all the great work we did during the COVID pandemic. COVID-19 globally killed 7 million people over 3 years. Averagely, 2.3 million people were killed by COVID-19 every year. Poor quality kills twice that number every year. 5.7 million. Twice that number. Twice the number of COVID-19 deaths every year. So it's not surprising that the Ministry of Health of Ghana, the Ghana Health Service, the Christian Health Association of Ghana, the National Health Insurance Authority, the private sector players have taken on the mandate to improving quality of care using internationally certified standards ISCO accredited safe care standards to benchmark rate healthcare in Ghana. Dr. Chag, in conclusion, the theme and focus of the Chag 2024 annual general meeting is aptly crafted to reposition Chag on the path of sustainable provision of quality healthcare for the millions of residents in Ghana who rely on the network for care. I wish Chag fruitful deliberations on behalf of Farm Access, and I thank you for your rapt attention. Thank you.
Thank you very much, Dr. Maswell. Another round of applause for him. Just so you know, we are streaming live. This program is brought to you by kind courtesy of all the facility managers that are here, pharmacists, mainly NS Chemists, Ozones, and other partners. Ladies and gentlemen, when we're having the speeches, the CEO of National Health Insurance Authority walked in the room, but I will give him time to brief. Aware that all the people here are expecting you. We have been expecting you since yesterday. So just take a brief. And he came with a bag. Let me also acknowledge the presence of Dr. Ame, the CEO Trust Hospital. We are happy to you. Ladies and gentlemen, let me now invite Dr. Philip Bano, Registrar of HEFRA, to give us his fraternal message.
Thank you, Doc. Dr. Chem, equally permit me to stand on existing protocol as I give my fraternal message. I'm going to be decidedly brief because a lot has been said. Country Director, those are very wonderful comments you've made and observations. I appreciate that, those comments. It's a great honor to be asked to join you today at this year's annual conference of the Christian Health Association of Ghana. I'm deeply grateful for the opportunity to share the incredible journey of the Health Facilities Regulatory Agency as we come together to discuss Ghana's journey towards the universal health coverage, addressing healthcare quality, and the emerging human resource challenges. In fact, HEFRA has worked or collaborated with many of the institutions that you see here, represented here, and I'm going to be brief about that. When we began back in 2019, there was only one standard that we had to inspect hospitals. If when you went there, you pick one standard, whether it was a district hospital or referral hospitals or tertiary hospital, it was just one standard. So we put some stakeholders together, and I'm happy to say that the leadership of your association was very, very forceful. And he was there in many of those meetings making contributions to make sure that we had the right standards and adopted it. Which means that if there's a standard that is too hard, blame him first before you come to blame me. For example, so after that journey, we drafted 35 standards for various facilities. Now we have 4 categories of hospitals. We have many diagnostic centers. We have many. For example, we couldn't agree. One of the most contentious issues we had to resolve was how many nurses do you need in a hospital? It took 2 weeks. 2 weeks. So you nurses who are complicated, forgive me. But equally complicated, difficult is how many doctors do you need? How many pharmacists? We had to resolve all these issues. How did I know that I had to fall back on WHO to determine how many liters of water must be reserved for a patient in a hospital? So all those standards, I'm happy to report to you, are drafted. And then when we finished, Ghana College of Physicians and Surgeons came. They want to review. So for each standard, they appointed 2 specialists to review to make sure that it's accepted. And I'm also grateful to the Ghana Health Service that also provided, I don't want to mention the name of the gentleman, the doctor, but he was there at all the meetings, making sure that we adopted the right standards. I'm equally grateful also to the National Health Insurance representative to make sure that we do not adopt a standard that NHIA was not going to agree with. Then we move from there to mobile online information system. So some of you have to license and register, have to come long ways to our regional offices, some even to Accra. We said that cannot stand. So we adopt the mobile online information system. So even as we sit here today, if we are thinking of opening a clinic, a hospital, a diagnostic center, you can start the application process right now, hefra.gov.gh, and then you can start and then give us all your information. That became possible with the assistance of the USAID has left. But they paid for a lot of that to make it possible. Let's give a hand of applause, even though they are not here. They paid for that. And then it came to making sure that we can digitize all the tools and the standards. And there we found Farm Access to be very, very helpful, a great partner in that journey. And now we have to move on to accreditation. So everything I've said is, please stand up. Please stand. I have to introduce all of you. Do you understand too? Very good. So they came, where's Boniface? Boniface is not here. Okay. So then came SafeCare, very gracious. Because to develop these accreditation standards, you have to spend a lot of money to do that. But we were very grateful to let us use their standards. I think it meets the standards in Europe, meaning the Netherlands, right? Netherlands. And free of charge, and then we can adopt some of them. And again, the leadership of Chag was the first to embrace them. So credit to the leadership that you have. And all of you that work. And I'm happy to learn that more and more provider groups, here in the private, of course, Ghana Health Service has embraced it, and others have embraced these accreditation standards. Soon, however, we will launch our own. It will not contradict what is already there. It will make it even better. And that we will push that. National Health Service is here. Yeah. Oh, I shouldn't have. So that a component of the reimbursement you have is reflected, quality of care is reflected in the component of the reimbursement. Is that fair to say? That's what we are working on. So we go from 1 star, say, to 4 star. Imagine each 2, there's a star is worth 2 or 3 additional compensation to you. Would that be worth it? So if you're supposed to get 100 CDs, you get a 1 star, maybe 3 or 6% is added to you. Is that okay? Oh, I'm not hearing. It seems like you're not too happy. If you are not happy, I'll keep my stars. So there are several models to look at, 1 star, 2 star, and 3. But I will know, mine is a fraternal message. And I think others have said a lot here. I'm very grateful for some of the important observations made about the speakers before me. I want to mention 5 things. I'm going to be very brief, and I'll say that. I believe quality of care begins with having the access to begin with. If there's no access, then nobody can address your problems. So there are 2 things that I observe in our Ghana model of delivery of care that are quite unique and very good. And I have to commend Ghana Health Service for that. That is the CHIPS compound, Community Health-Based and Planning Service. Am I right? CHIPS. Where you plan nurses in the community, people can go to them, direct their issues, or tell them their issues, then they direct or point them the right place to get care. It is very unique to Ghana, and I commend 430 deaths per 100,000 deliveries or births. In the 90s, now we have improved to less than 200. So we are doing something right, considerable improvement. But of those who don't make it, 49% is due to postpartum hemorrhage, bleeding. So what can these services that be provided by in the ambulance, at they allowed to transfuse blood? Are midwives allowed to transfuse blood? Can we adjust our curriculum somehow so that others can also give blood? What can we do to address that issue? The second thing I will mention is evidence-based practice. Evidence-based practice. Does this medication or therapy work? Is it proven to be superior? Are there any cost savings? Is newer therapy necessarily better than the existing therapy? Some of you may be doing the next thing I'm about to mention, but part of your assessment, new assessment, is going to include the adoption and the use of essential medicine list. The Ministry of Health maintains this list. We expect hospitals to have these medications. We want to see that you've adopted them. I'll move on to the third thing. Is patient-centered care. Perhaps the most important modality any facility can adopt to mitigate harm to patients is to have a policy centered on patient-centered care. Are patient complaints received and how are addressed? If you are the leader, medical superintendent, don't expect that you get to know everything going on in your facility from just your core leaders or core management team. Sometimes listen to the patients. They are the recipient of the care. And what they tell you, you must take it seriously and address them. In fact, if you look at facilities that have a policy and address this, you're going to have fewer risk management issues to address. So that is the part I want to leave with you. The next one is continuity of care. Continuity of care begins from the time of admission and it ends at the time of discharge, and sometimes even beyond. If a patient came to you from Hawaii, family, and everybody, you know from there he's going back home. But then there's a patient who's going to come off the street to you. Where does the patient go from here? And this thing sometimes is the social condition of the person that is making the patient health care worse and always coming back to the hospital seeking care. So we need to address that. Now, I can't burden you with all these responsibilities, but you must look for the resources in the community to help you address these matters. The last, the HR. That is you sitting here. Quality of care, if you look at our health.
As at 2019, 2020. And this also has implication. The last census showed that about over 1 million people are above the age of 65. That means that our geriatric care has to be set up and respond appropriately. And I'm hoping that will be some of the innovations that NHIA, which was started long ago in taking care of the aged, will do more. Antenatal care visits continue to hover around 88%, while the maternal mortality ratio significantly decreased from 302 per 100,000 live births in 2015 to 263 per 100,000 live births in 2020. Similarly, a more than 100% increase has been recorded in our universal health coverage index. By the year 2000, we were 24. In 2021, we are 49. So what it means is it took us 20 years to get here. Now we have about 6 years to go, and we are 49. So what we need is a lot of leapfrogging, a lot of innovative ideas that will sort of catalyze us into achieving the UAC goal by the year 2030. Ladies and gentlemen, there are health system challenges, and that's despite this significant progress I have mentioned in UAC, a number of challenges persist. Out-of-pocket spending as a percentage of the total expenditure continues to remain as high as 31% in 2020. The expenditure as a percentage of total health expenditure has generally hovered around 50%, so which means there's a lot that we need to do. Additionally, there are a number of quality of care and health workforce challenges. For example, it has become reported that some 134 million adverse events occur each year due to unsafe care in hospitals in lower middle income countries, resulting in 2.6 million deaths, as has already been alluded to annually. With over 80% of these being preventable. In Ghana, unsafe care occurs in the form of hospital-acquired infections, unsafe surgeries, wrong medications, transfusions, infusions, among others. Ladies and gentlemen, there's also the challenges concerning the numbers, skill mix, and distribution of our health workforce. A key health system building block, that's the health workforce. Despite the 100% increase in international health regulation health workforce core capacity from 20% in 2018 to 40% in 2022, this core competency continues to remain below the required average score of 50%. So we still have gap to address as far as the human resources is concerned. Maldistribution has not ceased since a major headache to managers in the sector. Ladies and gentlemen, almost 88% of all our medical specialists in Greater Accra region. 5 out of the 6 have no specialist. There's no dental surgeon in 5 of our regions. In terms of skill mix imbalance, as high as 57% of the public workforce are non-professional nurses, whilst less than 10% of our medical specialists are specialists as of December 2023. So that gives us a huge challenge as far as our human resources is concerned. And of course, that has impact on quality. So what are the things we need to do in catalyzing towards achieving UHC? Colleagues, so what are my reflections that I want to say? These quality of care health challenges, and how do we achieve UHC by 2020? Let's look at the health system. At the health system level, we must first begin to address the current augmentation of services as we have. Our ineffective referrals must be improved, and the lack of support and interaction between facilities which hinder efficient service delivery, especially at the district and the sub-district levels. To do this, we must to deepen our implementation of our country's UHC roadmap, where all 5 guiding principles recognize primary health care as a level of emphasis and the network of practice as the special purpose that we need to apply. In line with the guiding principle 5 of our roadmap, through the network, we can rationalize the allocation and spending of financial resources to focus on primary health care, as well as properly manage existing and new co-financing requirements and reduce fragmentation. For our health workforce, ladies and gentlemen, in terms of what I said, the UHC roadmap, it is about time we took a bold step to enhance our human resource efficiency at the district and the sub-district level. When we do an assessment, some of the results is difficult to share. For us, the Ghana Health Service, we have this being established, the Ghana Health Service Institute, to train and enhance the leadership skills of our managers to improve health outcomes, including improving quality of care. The GHS Institute shall leverage in-house capacity and industry best to collaborate, create rich, leading learning approach, leading and managing experience through blended learning, through a blended learning approach. Through the institute, we shall find local solutions to our model health center. Chag or Ghana is going to have a fiber wired to the place so that we can do telemedicine, able to communicate and be able to render services appropriately.
So we are bringing you the best. The good part is that the man who is the keynote speaker for today is the Health Bill and Melinda Gates Foundation. He is able to mobilize millions and billions of resources. He's versed in clinical trials. At the moment, he's the lead person for the Africa Higher Education Collaborative, funded by MasterCard Foundation. He is the chair of the Executive Steering Committee of the Africa Higher Education Collaborative for Africa and Canada. Ladies and gentlemen, he has mentored and trained over 30 PhD students and postdoctoral students as well. He is Perelman International Scholar at the University of Pennsylvania in the USA and serves on several boards locally and abroad. Ladies and gentlemen, I am pleased to introduce to you the pro of the KNUST. He has given a lot of Chag facilities opportunity. As you are aware, in recent times, they've trained over 2,000 health workers through the MasterCard Foundation, and Chag has been a part of it. Our executive director said he merges the academia with service delivery. Ladies and gentlemen, Prof. Owusu Dabo Ellis. And before I hand over the mic, as a young medical officer who took over King's Medical Center, he was the board chair. And he will always, if you present data, he will ask you, why is this? He doesn't accept data, he will ask you, why is this? Explain. And in many ways, I learned a lot. Prof, we are privileged to have you.
I thank you so very much, Dr. James Deere, with whom I serve on the King's Medical Center board. An excellent secretary to me. He makes my work very, very easy. And knowing that I'm standing between him and lunch, and for many of you, knowing that your glycemic index is low, I will have to try and make this a bit snappy. And thanks to the previous presenters, I think they've made the work pretty easy. And so I shall try to summarize through this keynote address. I was expecting to see the Minister of Health, our special guest of honor, the Honorable Dr. Bernard Okoboy. But permit me, Conference Chair and former Deputy Director General of the WHO, the vintage venerable, I didn't know you had this great sense of humor. You've made me laugh so much today. Your Excellency, Dr. Chair. It's indeed a delight. The last time we met, I was I was the executive chair for a local conference on KNUST campus, and at the time you had come in as our special guest of honor. It is indeed a joy to see you again. The Director General of Ghana Health Service, Dr. Patrick Abwajikuma, my good friend and brother. In absentia, the Lord Bishop, the Catholic Bishop of Koforidua, whom I got to know today again, giving us a choice between Ampesi and Fufu. And for those of you who are yearning for lunch, be careful of your choice. Chairman of the Chag Board of Trustees, Dr. Elias Sori, who mentored many of us, many colleagues, including myself. As a young medical student, we took inspiration from some of them when I was in the medical school. Executive Director of the Christian Health Association of Ghana, Dr. Peter Yeboah. It is a joy to meet you and to talk the linkage between academia and service. Our development partners, cherished development partners, foreign Commonwealth and development offices, UKID, USAID, the World Bank, and many of you who are represented here that I can go on and on. The national and regional executives of Chag, esteemed representatives of partner and sister organizations, including the CEO of Farmer Access and, of course, the NHIA. It is indeed a joy to meet all of you, and of course, in absentia, the HIFRA, the Ghana Medical Association, the HSWU, and of course, the FCDO. Representatives of the Ministry of Health, Chag facility managers, distinguished invited guests, friends of the media, ladies and gentlemen. When I was writing this speech, I thought it would be a morning by this time, but it's actually afternoon. So good afternoon. I bring you greetings from the management, students, staff, and stakeholders of the Kwame Nkrumah University of Science and Technology. And I'm indeed honored for this invitation to deliver the keynote address on a very important, what I consider crucial topic that is not only fundamental to our collective survival as a nation, but also the well-being of our country. It is pivotal in shaping the future of the healthcare system globally. The topic is universal healthcare coverage and its critical components of addressing healthcare quality and human resource challenges. On the 24th of December 1957, 9 months after the independence of Ghana, the president of that republic, our republic, Dr. Kwame Nkrumah, stated among other things that we, referring to his government and the people of Ghana, shall measure our progress by the improvement in the health of our people. I wonder what that great visionary would be thinking right now if he were alive today, to witness the progress made by this beloved country. Without question, some significant strides have been made in improving the overall health and well-being of Ghanaians. For example, the average life expectancy at birth of Ghanaians improved by 6.86 years from 59.2 years in 2000 to 63.6 years in 2021, according to the World Health Organization 2024. One must place on record that to achieve this improvement in life expectancy requires deliberate, systematic, collective actions and resolve. There have been several attempts at improving training and deployment of health workers in increasing numbers over at least the last 2 decades. Financial accessibility exists, but as has been noted by the Chief Executive Officer today of the NHIA, hiccups persist. Deployment of the CHIPS compounds by the Ghana Health Service and others, particularly for the Chag institutions, you must be commended for improving geographical accessibility across the length and breadth of this country. Despite these achievements, our healthcare system is plagued with multiple systemic bottlenecks. Access to essential services by population are unevenly and inequitably distributed. This has been alluded to by several of the presenters who came before me. Additionally, service availability and quality of care fall below expectations. While the negative attitude of some healthcare workers requires social surgical intervention, that is in quote, to deal with this malignant, pervasive canker. Thus, if we are truly to leave no one behind and ensure that every citizen and foreigner who reside in Ghana are able to access high-quality services, then the concept and principle of universal health care coverage should be fully embraced and operationalized. Universal healthcare coverage, as defined by the World Health Organization, means that all individuals and communities receive health services they need without suffering financial hardships and to the closest proximity. In fact, at their doorstep. It embodies the principle that health is a human right and not a privilege reserved for a select or fortunate few. Achieving universal healthcare coverage thus requires us to tackle two interrelated challenges head-on: ensuring healthcare of health quality and overcoming the barriers posed by human resource shortages and disparities. I'll touch a little bit on healthcare quality. According to Sir Martin Luther King Jr., healthcare should be a right, not a privilege. It should be a service, not a commodity. End of quote. Ladies and gentlemen, while access to healthcare services is crucial, the quality of those services is equally vital. I dare say that healthcare quality is not like beauty that is apparently held in the eyes of the beholder. There are global objective assessments and expectations of quality that must be upheld. Across the globe, we face disparities in healthcare quality with significant variations between regions, urban and rural, ethnic disparities, and even within individual healthcare facilities. These persist, and I'm referring to disparities. These disparities often lead to unequal health outcomes, perpetuating vicious cycles of illness, poverty, and eroding the gains made during the acquisition and attainment of the goals of the Sustainable Development Goals. Improving healthcare quality involves a multifaceted approach. It requires us to invest in robust healthcare infrastructure, ensuring that facilities are adequately equipped and staffed with competent workforce. It necessitates the implementation of stringent quality assurance measures, including the adoption of evidence-based practices, standard operating procedures, and protocols. Moreover, fostering a culture of patient-centered care, where individuals are actively engaged in their own health decisions. This is pivotal in enhancing quality healthcare outcomes. There are human resource challenges, as has been alluded to by several presenters, I'm sure yesterday and both yesterday and today. Health systems can only function with health workers who are well trained. Here we mean they are knowledgeable, competent, they are highly skilled. And they do not only have the head and the hands, but they also have the heart. However, countries at all levels of socioeconomic development face, to varying degrees, difficulties in the education, employment, deployment, retention, and performance of their health workforce. According to the WHO, we are currently facing a severe global health workforce crisis with critical shortages, imbalanced skills mix, and uneven geographical distribution of health professionals, leaving millions without access to basic life-saving health services. Indeed, the World Health Organization estimates a projected shortfall of 10 million health workers by 2030, when we are supposed to have attained the Sustainable Development Goals. Mostly, as you would imagine, these would occur in low and lower middle income countries. In Ghana, the situation is not very different. The latest Ghana Human Development Report revealed that about 24% of nurses train in Ghana and 50% of doctors are currently working abroad due to poor working conditions. And this is according to the UNDP 2024. Your Excellency, Dr. Chair, distinguished invited guests, ladies and gentlemen, the backbone of any healthcare system is its workforce. The dedicated professionals who provide care, often under challenging circumstances, as we find in our case. Yet, we are confronted with a global shortage of healthcare workers exacerbated by maldistribution issues, where rural and remote areas suffer the most. This shortage not only strains existing healthcare providers, but also compromises the accessibility, the quality, and continuity of care for millions. And I was told, I think only 3 or 4 days ago, because we've rolled out the primary healthcare series under the MasterCard Foundation, African Higher Collaborative. And I was told that 80% of all doctors and the Director General is here are resident in the south, the southern part of Ghana. And perhaps when you combine dental services, it's even worse. Ladies and gentlemen, to bridge this gap, we must adopt comprehensive strategies. These include investing in healthcare workforce, planning and development, ensuring that healthcare professionals are equipped with the skills and resources needed to deliver high care and very extreme quality of healthcare. It involves incentivizing healthcare workers to serve in deprived areas, and I'm very, very happy that that has been touched on this morning, providing them with the support and recognition that they deserve. The Ministry of Health's Human Resource Development Plan must be fully implemented to address inequities in skills and manpower. Moreover, addressing burnout and mental health concerns among healthcare providers will be paramount to sustaining a resilient healthcare system. A resilient workforce capable of meeting the diverse healthcare needs of our populations. We therefore need a skilled, highly motivated health workforce to achieve universal healthcare coverage. Distinguished ladies and gentlemen, turning our attention to policy and implementation in achieving universal healthcare coverage requires more than mere rhetorics. It demands concerted action at both national and global levels. Definitely, political commitment is essential in prioritizing healthcare as a fundamental human right. Allocating adequate resources to support its realization. We must forge partnerships across sectors, government, private industry, civil society, and certainly academia, where I come from, to harness collective expertise and resources towards achieving the ideals of universal healthcare coverage. Effective implementation of universal healthcare coverage necessitates robust monitoring and evaluation mechanisms to track progress and identify areas for improvement. And I'd like to suggest to you, Chief Executive Director, Dr.